Our next speaker is Mayra Guerrero, my co-moderator. She's going to talk about transcatheter mitral valve replacement for MAC. We've already alluded to it. She's actually really probably the best suited person in the world for this talk. So thank you, Mayra.
Thank you very much for such a kind introduction. I'm not sure about that, but certainly the very excited person about this project. So excited I cannot even speak. Okay, so this all started with isolated cases. The first two were transapical. I think they were done late 2012 and reported early in 2000 or mid 2013. And our colleagues, Henry Ford and I, including Adam, who's in the audience, were the first ones to do a percutaneous case. It was exactly August, 4 years ago in 2013. So it started with isolated cases, and there have been other technologies that have been used, also isolated reports with direct flow and Lotus valve in MAC, and as we saw earlier from Paul Saraja, Tendyne in MAC. So Lotus is no longer, it's on hold, and direct flow is no longer available. And Tendyne, the experience is early, so therefore what we know now, the most is based on the experience of balloon expandable aortic transcatheter heart valves from the TMVR and MAC Global Registry. So we presented the one-year outcomes at EuroPCR this year. This analysis included 116 patients. The data log was May 1st, just a couple of months ago. So out of 116 patients, there were 29 deaths at 30 days, so 25% mortality. 106 patients had the procedure done 1 year prior to the data log, and therefore they were eligible for the one-year follow-up. So 10 had the procedure after May, and therefore were not included in the one-year follow-up analysis. So there were 77 patients who were alive after 30 days and eligible for the one-year follow-up. There were 28 additional deaths after 30 days, and that leaves us with 49 patients alive at 1 year after TMVR. The mean age was 73, 68% were female, most of them in class 3 and 4 with multiple comorbidities. 52% had prior AVR, prior to the transcatheter mitral valve replacement, and the STS score was 15.3%, so an extremely high-risk patient population. The ejection fraction was preserved. The mean mitral valve gradient was 11.5 millimeters squared. PA pressure was 58, so about a third had grade 3 plus or more MR, and only 6% had pure MR without stenosis. So most of these patients had mitral stenosis as the predominant pathology. These are the SAPIEN, the type of valves used, most of them in the SAPIEN family. A couple of innovative valves, since they are balloon expandable, they were included, but most of them were SAPIEN 3. 20% transatrial, and about half and half of the remaining patients were transapical or transeptal. Technical success defined by the MVR criteria was about 77%, and this was primarily limited by the need for second valve in 17 patients and LVOT obstruction with hemodynamic compromise in 11% of the patients. So we already mentioned that the 30-day mortality was 25%, about half and half cardiac and non-cardiac. But at 1 year, half of those patients were death, and most of the late deaths were actually non-cardiac. The cardiac deaths are in this slide. LVOT obstruction was an important cause of those deaths. After 30 days, there were 2 valve thrombosis cases and 3 cases of endocarditis. There were other adverse events. Mitral valve intervention was needed in 9 patients within 30 days and only 4 after 30 days. The type of mitral valve intervention within 30 days were mostly paravalvular leak closure in 4 of them, transeptal valve in valve due to central MR in 1, and 1 paravalvular leak were 2 transatrial TMVRs, 1 for embolization and 1 for LVOT obstruction, and 1 surgical MVR for MR. There were only 4 after 30 days, 1 of each category. The outcomes of patients who had LVOT obstruction with hemodynamic compromise was poor. 5 patients were treated medically, they all died. 1 patient was treated with kissing balloon aortic valvuloplasty and balloon mitral valvuloplasty. The patient also died. 1 patient was treated with surgery, died on the table. And the patients who were treated with alcohol septal ablation were the ones who actually had a little bit of better outcomes. 4 of those patients were actually discharged from the hospital, and 2 remained alive at 1 year. We did a multivariate logistic regression analysis, and we found that LVOT obstruction was an independent predictor of 30-day and 1-year mortality. and technical success was an independent predictor of improved mortality or survival. So we need to have a good success without LVOT obstruction to improve survival. This is a Kaplan-Meier curve at 1 year showing half of those patients were death, but there were many deaths within 30 days. And when we did the landmark analysis after 30 days, what we can see is that if patients survived the 30-day post-procedural period, most of those patients were alive at 1 year. The valve performance was also maintained at 1 year. The mean gradient was around 6. And 75% of those patients had none or trace mitral regurgitation. Those are the gradients at baseline, 30 days and 1 year, so maintain performance. And importantly, the symptoms improve in survivors. Most of them were in class 3 and 4 in orange and red at baseline, and at 1 year, most of them were in class 1 or 2. So the key is to help them survive the 30-day post-procedural period by improving our technical success and preventing LVOT obstruction to have more survivors who feel better. So we've been focusing on predicting LVOT obstruction. This work is from Didi Wang from Henry Ford, who looked at 5 patients who had LVOT obstruction and compared them with patients who did not have LVOT obstruction. And at least what we know so far is that if you have a neo-LVOT area of more than 250, then you have no gradient whatsoever, but there's a gray zone, just like it has been mentioned in prior talks. So we don't know what the true minimum is. Could be 180, could be 170. There are many factors that are involved, and we're working on that. We learned that alcohol septal ablation is a strategy that can work as a bailout. 6 of those patients, were treated successfully. There was reduction of gradient in all of them, and 4 patients were discharged from the hospital. But since one of them had a recurrent LVOT gradient the following day, that made us change our strategy, and now we do preemptive alcohol septal ablation to prevent LVOT obstruction. And since then, we have treated more than 10 patients successfully. They were at high risk, and they already had a TMVR after alcohol septal ablation done 6 or 8 weeks prior to TMVR. And these pictures are from our last case at Evanston 6 weeks ago. This is the CT at baseline, 18 millimeter septal thickness. This is after alcohol septal ablation. This is the neo-LVOT area at baseline, 170, so below the gray zone. And the neo-LVOT area after alcohol septal ablation of 250, so adequate for TMVR. This is a transeptal TMVR, 29 sapien 3, and absolutely no LVOT gradient. For patients who do not have anatomy that is favorable for alcohol septal ablation and are candidates for transcatheter approach, we often perform resection of the anterior leaflet, and that takes care of the risk of LVOT obstruction. So in the mitral trial, this has been our strategy, alcohol septal ablation preemptively to prevent LVOT obstruction, and since then we have not had a case of significant obstruction or a death related to that. We're done with 2/3 of the enrollment, so hopefully we'll be able to give you some results. And I know Adam will talk later about a percutaneous option to lacerate the anterior leaflet to decrease the risk. So in conclusion, TMVR with balloon expandable aortic transcatheter heart valves is feasible in severe MAC. It is associated with procedural complications and a high 30-day mortality. LVOT obstruction is an independent predictor of mortality, both at 30 days and at 1 year. So efforts should be made to predict and prevent LVOT obstruction, and cardiac CT analysis is crucial in the prediction of LVOT obstruction. Now, patients who survive the 30-day procedural period have sustained improvement of symptoms at 1 year. Reintervention rate after 30 days is low. Valve performance is maintained at 1 year. Most deaths after 30 days were non-cardiac, so we must avoid cohort C patients to improve the overall long-term outcomes, and prospective clinical trials are needed and ongoing. Thank you.
Go ahead, John.
Mayra, in a ring, it's very discrete and thin, and the calcification, which is your anchor in MAC, can be very broad and irregular. So when you make your measurement for LVOT size, do you bracket it? Small differences can make a difference in your measurements. How do you manage that?
So, we place the transcatheter heart valve, in this case, balloon expandable valve. We aim for a final 80% ventricular, 20% atrial position of the valve. And we also take in consideration flaring. So, for example, I showed you a 29 millimeter sapien 3. When we use a computer software that I particularly use Tremensio, I have no connections with any company. I just happen to know that one. And I flare, when I place the virtual valve, on the inflow, I leave the 29 millimeter, and on the outflow, I measure 31. because I don't want to underestimate the risk of LVOT obstruction. I know we want to flare the valve, so I'm going to put 31 millimeter distal in the ventricle at 80-20. And it's at that lowest portion of the transcatheter heart valve in the left ventricle where we are in closest contact with or in closest proximity to the septal bulge or the interventricular septum, and right there we measure the neo-LVOT or whatever is the closest. And if it's in the borderline zone, if it doesn't pass the initial screen of more than 250, then we kind of naively place the valve a little bit more atrial, and we say, okay, how about if we go a little more atrial? And you do see the change. So we got 70-30, 70 ventricular, 30 atrial, or 60-40. I don't want to pass the 60-40. I think 50-50 is too dangerous because this is naive. We say 60-40, and you may end up 40-60, or sometimes it's difficult to really leave the valve where you want. So the short answer is yes, we do, but with some caveats, like you really cannot control where exactly you land.
So have you seen any issues when you go 60-40 instead of the 80-20? In terms of, I guess you're worried about it embolizing into the left atrium or not seating properly. I mean, you haven't seen that.
No, I think if it's properly sized and
right.
you flare, I think.
But do you think we need to do 80-20 because that
I think we need to do 80-20
because that puts you more at risk probably.
The patient I showed you, I showed you the outcome of the procedure because of timing restrictions. But she came back with fluoro. We do the fluoro at 30 days. She came back and it actually migrated 3 millimeters more atrial. And came back actually with hemolysis. She's doing fine. She's at home. We didn't have to do a reintervention. But when we looked at the post-procedure CT, the fluoro, and the echo, there was atrial migration. We had 80-20 position, so you kind of can afford to have a little bit of migration. The valve will find its own position, and it's much better to if you can 80 to allow for that.
There's some of us have some experience with placing the sapien valve surgically through a direct left atrial approach, and I don't think we're as aggressive about putting as much into the left ventricle. In fact, we want to see the entire cuff in the left atrium because we'll use that to anchor any few sutures we put in. So I think we're probably closer to 60-40 when we're doing it surgically and not 80-20. But then again, we also have the luxury of having some sutures to potentially help keep it in place. So that's interesting.
That's one more question. Do you have any concern about the diastolic wall thickness when you're doing a preemptive alcohol ablation? I know in hypertrophic cardiomyopathy that's what we're after. Here you just don't want to perforate and understand. Is that something you look at, or you have no choice and so you do it?
No, we do look at the septal thickness. Yeah, very good question.
Because your images are in the system.
You mean at the septal thickness? You're right. Yeah, so we didn't show all the pictures. No, yes, we do worry if, or septal, I think the smallest that we have treated is like about 50 millimeters, but we have had a lot of discussions, and when it's borderline, we don't. So that's why I mentioned patients who do not have favorable anatomy, patients where the septal thickness is not even thick. So it's not one of the factors. This is multifactorial. There may be other techniques like a Lampoon procedure, that may be more beneficial for that particular patient.